Thank you all for attending this talk. I'm Karthik Bhat, and I will be presenting the paper Towards Intermediated Workflows for Hybrid Telemedicine. This work was advised by Dr. Mohit Jain and Dr. Nipun Kwatra at Microsoft Research and by Dr. Neha Kumar at Georgia Tech. We did this work in collaboration with Dr. Karthik Shamanna at the Bangalore Medical College and Research Institute. Telemedicine, as many of you may be aware, is increasingly being viewed as an affordable and viable pathway to care across the world. Advances in remote presence technologies and healthcare technologies have made providing remote consultations and care more and more feasible. There's also been a particularly renewed demand for and interest in telemedicine as a result of the COVID-19 pandemic that really strained healthcare infrastructures around the world. But it's not all sunshine and roses when it comes to telemedicine, because there are several known shortcomings to this approach that have restricted its usefulness as a pathway to care. One primary challenge is that doctors are unable to conduct physical examinations or any other sort of physical diagnoses for anomalies, which means that it is experienced as a subpar consultation when compared to the in-person modality. Similarly, telemedicine technologies, especially when they are repurposed communication technologies like WhatsApp and Zoom on smartphones and laptops, also fall short in terms of providing doctors with a view of diseased areas, especially if they're internal to the body or hard to reach. These problems do not yet have scalable solutions that can bring telemedicine out from the margins of healthcare and develop into a reliable modality for quality and patient-centered care. So our work seeks to address at least some of these shortcomings through intermediation. That is, by having an intermediary perform some tasks on behalf of the doctors, we want to understand if such intermediary workflows for teleconsultations would be acceptable to patients and doctors, and what some benefits or drawbacks of these approaches would be. So we asked, how does an intermediate workflow for telemedicine impact the care experiences of patients and doctors? In the interest of time, I'll cover only high-level details of our methods. Please do read the paper for justifications of our research design choices. We conducted this research within the ENT domain that looks at the ear, nose, and throat, with a specific focus on ear conditions. We did this for two primary reasons. First, it's a great example of health conditions that existing telemedicine approaches do not serve. There are few, if any at all, telemedicine services that are designed to aid ENT specialists in teleconsultations, given that they need to examine interiors of the ear canal or the nasal canal and so on. Secondly, prior research in the field of ENT had found through retrospective case studies that doctors could have had accurate diagnoses and treatment plans when patients' history was supported by images and videos. So both of these indicated to us that this was a domain perfectly poised to answer our research question. So we conducted this research at two ENT clinics, one in a public hospital and one in a private hospital in Bangalore in India. We recruited 27 patients among those who visited the clinics for their ear conditions to be part of the study. They would be the ones who received the intermediate consultation as a second opinion with other doctors. We took measures to ensure there were no risks of harm by virtue of their participation in our study, and we detail these methods in our paper. And we also recruited 9 doctors to provide these patients with teleconsultations. They were from the same state, so that they all spoke the same language. Our data collection comprised of ethnographic observations in these clinics over a 4-week period, and interviews with 6 of the patients who had these intermediated consultations, and 9 doctors who provided these consultations. These interviews focused on their experiences with this workflow and comparisons to any in-person or regular teleconsultations without the video capture that they might have had in the past. So moving on to some details about what our workflow looked like to paint a clearer picture of our methods. So in an in-person consultation for ear conditions, a patient typically goes into a doctor's clinic where the doctor uses a medical device called an otoscope, like pictured here, to look into the patient's ear for any anomalies or any other indications of disease. So this, coupled with the interaction between patients and doctors, where the doctors ask them questions and collect medical history, allows the doctors to make diagnoses and come up with treatment plans. So our intermediated workflow sought to emulate this just for teleconsultations where the physical examination is not possible. So we recruited and trained some intermediaries. In our case, it was undergraduate medical students or nurses, to capture a generic 30-second video of an otoscopy on a patient using a small portable otoscope. This cost around 2,000 rupees or about $25. We then forwarded these videos to one of our recruited doctor participants and had the patient teleconsult with this doctor so that the doctors could ask questions and collect medical history in order to make diagnoses. Our goal here was to see how such intermediated flows affect telemedicine and how patients and doctors compared these, like this intermediated flow, to other modalities of consultations that they had prior experience with. So I highlight some of our key findings here. The first important finding was that having intermediated workflows did address some issues that we highlighted earlier. Having images or videos to support them allowed doctors to more accurately collect medical history and diagnose conditions. It allowed them to rule out certain differential diagnoses for symptoms and arrive at conclusions more easily, therefore allowing for better treatment for patients. So one doctor summarized this as, when an otoscopy is done correctly, I can see the perforation. I can see if there's a discharge or not. So all of these things make it instantly clear what would otherwise take a lot of investigation. It takes the guesswork out of the arrival of the diagnosis. The next key finding that we want to highlight is how doctors' approaches to care work differed based on the modalities of interaction. This becomes particularly interesting as we consider what it takes to improve care provision through the telemedicine modality. So in person, we found that doctors accented the affective aspects of care. That is, they invested in making patients comfortable, being patient and listening to them, diagnosing and explaining the diagnoses to them, and overall providing a holistic care experience. D6, one of our participants, described this as, something that I like to do is I talk to them about personal stuff. I generally take about 15 to 20 minutes in a patient's consultation. And I like to take it slow, because if you give them the time, they're happy to come back. That's how I build relationships with my patients. Somewhat to the contrary, we noted that doctors across the board perceived telemedicine as a modality where holistic care was unnecessary, partially because it was also unviable due to the socio-technical gaps. Instead, telemedicine became a modality where problem solving and decision-making were considered key, more than the more affective aspects of care were seen as dispensable. On this, D6, the same doctor from the previous quote, said, I just needed 1 minute or two and one or two questions, and that's all I required to get the diagnoses. I don't actually need to talk to the patient after viewing the video, which was a proxy for the examination that they would have conducted. Another doctor added how he perceives teleconsultations as, in a week, I see almost 100 to 150 patients by teleconsultations only. Most of the patients just want the disease to be cured. They want some prescriptions, and for that sake, they will take a teleconsultation. So ultimately, what we're observing is a rise of telemedicine as an alternative pathway to care, not in so much as replacing or doing everything as in-person care, but instead prioritizing certain aspects of care. So patient decision-making around the choice of modality then becomes around balancing the need for affective and comprehensive care against the travel and waiting times associated with seeking in-person care. Our final key finding was around some of the challenges associated with scaling and operationalizing intermediate consultations that would, as we say in the paper as well, warrant further investigation. There are some concerns and considerations among participants about where training to the intermediaries ended and the need for formal medical education began, particularly considering some of the risks associated with medical care. Secondly, some doctors pointed out that there's a potential for abuse of the intermediary-based system that would need to be considered in making it operational, explaining that if you give this sort of thing in the hands of a pharmacist, they can start their own consultation. That thing is already going on. They'll say, I know this problem, the doctor will give this medicine, you take this. And it becomes that he might end up taking money from the patient saying, give me rupees 200 instead of paying rupees 500 to the doctor. So quickly to summarize some of the key takeaways from this work, we found how intermediation and other such approaches could bring telemedicine closer to the ideals of patient-centered care, that is, empowering patients to be more engaged and in control of their own care. In our discussion section, we present the parallels between patient-centered care as it is studied with regards to in-person care and what it might mean to shift that focus towards telemedicine. And second, we found how telemedicine was fast being established as a parallel pathway to care that prioritizes certain needs and deprioritizes others. Throwing intermediated workflows into the mix, our discussion section argues how the future of formal care work could look like with these two modalities coexisting as primary pathways to care, and what questions and avenues for future research that surfaces. So thank you all so much for listening. Please do check out our paper for more details.